of our lecture, we will learn what is the objectives. Inshallah, by the end of this lecture, you will be able to neonatal sepsis, its incidence and impact on the life of neonates. You will be able to understand why the neonates are at high risk for sepsis, and you will be able to put a clinical classification of neonatal sepsis and identify the risk factors for neonatal sepsis. And you will describe the clinical manifestations of sepsis, and of course, you'll be able to approach for neonate or with suspected sepsis and apply the guidelines in treatment of sepsis. And finally, you will participate in the prevention of neonatal sepsis. Firstly, we have to know the definition of sepsis. As you see here, this is the newest or this is the latest definition of sepsis in general, whether neonatal sepsis or else. According to the third international consensus definition for sepsis and septic shock, which is called the Sepsis 3. This is published in February 2016, and it is simply summarized to be the life-threatening organ dysfunction due to a dysregulated host response to infection. So infection, if the response is dysregulated, it will be to life-threatening organ dysfunction. So this is called the Sepsis 3, as I said. And according to this definition, sepsis is not a disease per se. It is a risk group of diseases. If we come to septicemia, I know you heard a lot about septicemia. It is, or sometimes we can call it a bacteremia. Septicemia, it is a serious bloodstream infection. So it is the presence of the pathogens inside the bloodstream or inside the circulation. Septicemia and sepsis are not the same. We cannot use the sepsis interchangeably with septicemia because sepsis is a serious Now, for example, if we take this picture and we can see here, firstly, the source of infection or the port of entry of a pathogen to the body as example for the respiratory system. So if the pathogen goes inside the bloodstream or inside the circulation, this will lead to what's called the septicemia or bacteremia. So presence of bacteria or its toxin inside the circulation. If the bacteria or its toxin leaking out of the circulation, it will go to involve a lot of organs other than the primary source of infection, like the heart, the kidney, the liver, the brain, and this will lead to what is called the multi-organ system dysfunction, and the eventual fate for this sequelae, it will be the death. So this is started with a localized infection, then it will go to be a sepsis that is ended with death. If we go to the definition of neonatal sepsis, because we are talking about neonatal sepsis specifically, it is the clinical syndrome of systemic illness that consists of physiologic, pathologic, and biochemical abnormalities induced by septicemia that is occurring in the first 4 weeks of life. And actually, it is difficult to clinically exclude the sepsis in newborns or in infants less than 90 days. 90 days mean 3 months of life. Those expressing a fever, which is regarded as more than 38 Celsius, especially in those born before 28 weeks of pregnancy. So that's why we extend to the 3 months of life, because if you calculate the gestational age, 28 weeks, and you can add 12 weeks to it, reaching to the term baby, which is the ideal term baby or full term baby, which is 40 weeks of life. So why we can extend The definition or the duration of neonatal sepsis up to 90 days of life. Of course, neonatal sepsis, it is one of the most important cause of mortality and morbidity in newborns. And this is real in our practice. We lose many of neonates because of sepsis, even if they overpass the primary complications of the neonatology, like the prematurity, but this will add a burden to be undergo the sepsis and complain the complications of. So, of course, neonatal sepsis, it is the most important cause of mortality among the low birth weight and preterm babies, as I said, especially in developing countries where the health resources or the health care and the medical care is, of course, of low source. Now, we say neonatal sepsis, it is very important. Importance comes from its high incidence. So in the United States, which is the highly advanced in medical care, it's about 1 to 8 in 1,000 live births. But worldwide, it may extend to 21. The sex predilection in male, of course, it will be more than female. For premature babies, we talk about premature babies, infection rate will increase 5 times more than the full-term infants because of the complications of prematurity. So according to the birth weight, you can see how the incidence increase when the baby is less than 1,000 grams of birth weight. So what about the mortality due to sepsis in general? Also, it is high. So it is worldwide, it is about 70%. It's very high. But in the United States, it comprises about 15% of all neonatal death, whatever the causes of a neonatal death. Now, I think you remember this picture showing statistics of causes of 4 million neonatal deaths worldwide each year. And here you can see the sepsis, whether it's pneumonia, tetanus, or diarrhea, how the percentage or how the incidence of sepsis and death due to sepsis. Now, if we go specifically to talk about the incidence of meningitis, because this is a very serious form of neonatal sepsis, so we can say that it is about 2.8. It's less than sepsis in general, but worldwide, and it may be less than 0.5 per 1,000 in the United States. While in bacteremic infants, bacteremic infants, we say the presence of the bacteria or its toxin inside the circulation, it will be about 23%, increasing in the percentage. The mortality due to meningitis, you can see here it is maybe 60% worldwide and 4% of all neonatal death in the United States. Well, now the incidence of culture-proven sepsis, and we will know later on in this lecture what we mean by the culture-proven sepsis. It's about 2 in 1,000 live birth world. And it is about 3 to 8% of all infants evaluated for sepsis. So the culture-proven, comes after the evaluation of patients that may express or that may be suspected to have sepsis. Now, we come to the very important issue in our lecture today, which is the fact that said neonates are more susceptible to sepsis, more than other age group. The question is why? And the answer is 2. First is immature immune response, and the second is genetic predisposition. Now we will know what happened in the neonates. Normally, what happened when the pathogen entered the body? That happened normally, unusually. So the neutrophils will move in to the site of the entrance of the pathogen, and this will lead to the initiation of a process of chemotaxis by chemoattractant to surround the pathogen and counteract its toxins. So this process need the further process called opsonization by presence of opsonin, which is antibodies, which cause the phagocytosis to engulf the bacteria. And finally, the monocyte will kill the pathogen and causing the apoptosis of the pathogens. This is what happened normally, but this is a process that happen normally and smoothly in the normal immune system cannot happen easily in neonates. So why? What makes the neonate immune system immature? Firstly is the neutrophils are deficient in their ability to adhere to the vessel walls at the site of infection, with decreased ability to deform, to change its shape, and to migrate into tissues. You can see here in this picture. The first process is the neutrophils will adhere to the vessel wall, and it will transmigrate through the vessel wall to the side. Then the process of chemotaxis and phagocytosis and apoptosis will. So when the defect here in the adherence and in the transformation of itself, changing its shape, and so this is the first step, or will be defective. The second is when the neutrophil have decreased chemotaxis due to decreased chemoattractant. So even when the transmigration of the neutrophil happened to the circulation, outside the circulation, as you see here, to the tissue, so the chemoattraction on the process of the chemotaxis will be defective. Then the third is the decreased amount of opsonins. The opsonins, simply, it is antibodies that promote the process of opsonization. So when there is a defect in the receptors or in the antibodies, so the process of opsonization and the phagocytosis will be defective. And finally, when we say the monocyte kill the pathogen, the neonates are deficient in monocytes. Now, the second issue, or the second cause why the neonates are deficient in their response, it is the genetic predisposition. So there will be a process of polymorphism. The polymorphism, this is of the immune system. This can cause an over or under expression of proteins and or the genes that have significant role in the immune response. It may be either more than required or less than required. And this is according to genetic predisposition. Now we will come to know what are the major rules for the baby to acquire the infection. We can say it is a perinatal infection. During or shortly after the delivery or after birth. So as you see here, if we start with the red, it is a blood-borne, or what we call it, transplacental infection of the fetus. And this is, as example, the cytomegalovirus, rubella. We will talk about this in the congenital infection or torch infection in the next lecture. Then it may be due to infection on passage through an infected canal, birth canal, or exposure to infected blood, like what happened in herpes simplex virus, hepatitis B virus, or bacterial infection. Or the third route of acquiring the infection is by ascending infection with disrupting of the barriers provided by the amniotic membrane. That's what's called, the example, the premature rupture of membrane that especially happen if it is more than 18 hours before initiation of the labor. Now we will go to a very important issue in our lecture, which is the classification of neonatal sepsis. We can classify the neonatal sepsis into two main categories according to the clinical onset of the manifestation of sepsis. So first, what we call it the early onset sepsis, which is when the onset of symptoms before the 72 hours of birth. And the other is the late onset sepsis, when the onset of symptoms started after 72 hours of birth. So that's why for those attending for the clinical session of the pediatrics, we actually, and we insist to know the exact age of the baby, because one of the differentiations and one of the findings is the onset of sepsis according to the age, which is in just calculated in hours, especially in the first 4 days, especially in the first 96 hours of life. So if you go to the details of the early onset sepsis, it's often present, as I said, in the within the first 72 hours of delivery, but the presentation will be a fulminant or multisystemic illness. It's mainly due to bacteria acquired before and during delivery. So it may acquired, as you see, during delivery or before. And it manifests frequently. What is the manifestation frequently of early onset sepsis? Pneumonia, and less commonly as septicemia or meningitis. This is reserved for the late onset sepsis. The mortality rate due to early onset sepsis is very high, up to 50%. What are the pathogens of early onset sepsis? Firstly, and the most common is the group B beta hemolytic streptococci, or what we call it GBS. Then the gram-negative enteric pathogens may cause it. Non-typable H. influenzae, the enterococci, Staphylococcus aureus, and other streptococci, and finally the Listeria monocytogenes. Now, what are the risk factors for the baby to get the early onset sepsis? Actually, we have two groups, maternal and neonatal, because we say it may be acquired before or during or shortly after birth. So the maternal factors, maternal fever, maternal chorioamnionitis, and genitourinary tract infection, genital GBS infection, and diarrhea, premature rupture of membrane if it is more than 18 hours of before the delivery. This is regarded as a risk factor. The foul smell amniotic fluid, and multiple PV examination, difficult or prolonged labor, and of course the poor socioeconomic status and poor nutrition and hygiene. So these are the maternal factors. What about the neonatal factors? Of course, on the top of list is the prematurity and the low birth weight, perinatal asphyxia. You remember the perinatal asphyxia. It is the mother of all problems. Vigorous resuscitation, invasive procedures because of the asphyxia, aspiration of meconium, congenital malformations, example, the meningomyelocele, and male neonates. Male neonates regarded as risk factor, and it is about 2 to 6 times higher than female. Now, if we talk specifically about the premature rupture of membrane and chorioamnionitis and its relation to the early onset sepsis, the premature rupture of membrane, it is easy to describe. So what about the chorioamnionitis? Chorioamnionitis, I see, it is the intraamniotic infection that indicate the infection of the amniotic fluid, amniotic membrane, placenta, or the deciduum. So what is the relation between them and the early onset sepsis? Incidence of early onset sepsis in general is about 2 in 1,000 live births. But if premature rupture of membrane occurs more than 24 hours prior to delivery, the infection rate will increase to 1 in 100. Look at the difference. 1 in 100 if the probe occurs more than 24 hours of life. Presence of chorioamnionitis will increase the sepsis risk by 2 to 3 times. So if there is probe with chorioamnionitis, the infection rate will increase further to 1 in 10 live birth. Incidence of early onset in general is 1 to 2 in 1,000. Presence of a probe and chorioamnionitis making it in 1 in 10 just. So what is the relation between the prematurity and low birth weight? Well, this is the problem. Why? Preterm babies are deficient in immunoglobulin concentration and complement function, of course, and phagocytic. All the problems that we said about why the immature, the immune system of a neonate is immature will be more complicated, will be more deficient and immature in a preterm baby. This is, of course, will happen. So preterm baby, as we say, have 5 times higher risk of developing sepsis than term infants. Presence of chorioamnionitis may coexist and may trigger for preterm labor itself. So presence of chorioamnionitis with low birth weight will increase the sepsis to 16% if we compare it to association with normal weight baby. Now we will go to the perinatal asphyxia and its relation to the early onset sepsis. Of course, it will associate it with depressed immune function because of the hypoxia and because of the acidosis. This will affect the immune function and the immune response. Several intervention procedures will increase the risk of infection. You know, the perinatal asphyxia need excessive resuscitation. We will use devices to resuscitate the baby. So this will cause an outlet, and the inlet of the pathogens to the babies. Low Apgar score, which is regarded as 6 or less at 5 minutes, will increase the risk of infection to 4%. And this is one of the importance of the Apgar score. We can expect the likelihood of sepsis in that baby. Low Apgar score and presence of premature rupture of membrane, more than 18 hours, will increase the risk of infection to 27%. Now I will go to the late onset sepsis. In late onset sepsis, from its definition, the onset of symptoms is usually developed, delayed beyond hours after birth. So this is the clinical definition. Appearance of the symptoms after completing 72 hours of birth. So what is the causes? We say for early onset may be acquired perinatally. For the late onset sepsis, this is caused by organism in the external environment of the home or the hospital. Baby inside the neonatal intensive care unit may acquire the infection from presence at that point, or even presence at home. So this is a community acquired, or the medical worker what may be the source of transmission infection. The late onset sepsis is often transmitted via hands of care providers, as I said. So it can present as fulminant sepsis or localized infection, while the early onset, it's mainly as fulminant. So the presentation is subtle. We mean by subtle, it is vague. And there is no clear-cut picture for the presentation of sepsis, but often associated with meningitis. You remember when we talk about the early onset, we say it is unlikely to present it as meningitis. Mortality rate due to the late onset sepsis is more than that due to the early onset. It's maybe up to 6% only. So what are the pathogens of late onset sepsis? Coagulase negative staphylococci in indwelling CV line. What do we mean by this? Baby may have an umbilical catheter or NG tube or IV line. So this is called, or even Foley catheter. This is called an indwelling CV line. Of course, this will be a cause or a risk factor to develop the late onset sepsis, and specifically the coagulase negative staphylococci. Staph aureus, maybe. Gram, GBS. Other gram-negative organisms and candida species also may cause late onset sepsis, although it is a fungal. What are the risk factors for late onset sepsis? Here is the risk factor related to the baby, not to the mother, because we say it started after 72 hours of birth. So again, prematurity and low birth weight, and I know why the prematurity and low birth weight, it is a high risk factor. Prolonged hospitalization and previous antibiotic use may develop resistance. Presence of foreign materials like endotracheal tube, catheters, invasive procedures like cannulation may be source of infection. Will lead to early septic shock with decreased capillary refilling and the low mean arterial blood pressure, which can be reversible with appropriate treatment. But if left untreated, so this state of the septic shock will gradually or quickly will be converted into refractory shock and will lead to multi-organ dysfunction and even death. I think this picture can show or can explain the sepsis syndrome. Here is the survival rate launching to the death. So the infection by presence of pathogens will lead to sepsis. The sepsis will cause organ dysfunction. This will lead to severe sepsis. And if there is refractory hypotension, there will be septic shock. If left untreated, the refractory septic shock and multiple organ dysfunction. And the process here moving from the survival toward death. Now, what are the clinical manifestations of neonatal sepsis? They are often vague. As we say, it is vague, septal. So this necessitates a high demand of index of suspicion for early diagnosis. You have to be highly suspicious about the sepsis. Suspect the patient to have sepsis because it is very serious and work according to this. So possibility of sepsis must be considered with any clinical deterioration unless the event is readily explained by other causes. Like what? I will give you an example. Baby is lethargic. His activity is decreased. So if you exclude the cause of decreased feeding, the mother didn't give feeding to the baby, and this will cause hypoglycemia. So suspect this is a sepsis until proved otherwise. This is a very simple example. So what are the most common presentation in general? In early onset sepsis, it is respiratory distress. So we say it's fulminant, and it's mainly presented as pneumonia. While the alteration in feeding behavior, as I said now, mean lethargy, poor feeding. So in general, sepsis involve a lot of systems, most of the systems. So generally, the sepsis cause lethargy, jaundice, and temperature instability, maybe high temperature, hypothermia or hyperthermia, involving the respiratory system in form of respiratory distress and even apnea. The cardiovascular system by arrhythmia, hypotension, and shock. Metabolically, it will cause unexplained acidosis. The CNS involved by the lethargy, irritability, seizures, and bulging fontanelle, which are the manifestations of meningitis. The GIT involved in form of poor feeding, vomiting, abdominal distension, and bilious aspiration. The skin, it's involved by petechial rash due to thrombocytopenia, bleeding and puncture, and sclerema. I will show you what is sclerema because this is new to you. Sclerema is a diffuse hardening of the skin and subcutaneous tissues, and it affects the premature more than the term baby. All newborns of severe sepsis with poor prognosis. Actually, in our practice, presence of sclerema, it indicates the poor status of the baby and indicate the poor prognosis when we reach to the stage or to the level of sclerema. So sclerema, as you see here, hardening of the skin and subcutaneous tissue. We can see it in the lower limbs mainly, more than it may extend to the upper limb, or it may extend to involve all the skin. Now, how we diagnose the sepsis, whether it is early onset sepsis or late onset sepsis. The early and efficient diagnosis of neonatal sepsis remains a difficult task. It is not simple and it's not easy because of the non-specific nature of presentation. So why the neonatologist should be of the high suspicion to the presence of the suspected sepsis. So the spectrum and the severity of the symptoms required to decide in evaluation for sepsis is a matter of clinical judgment. Here is the clinical judgment is very important. You have to be suspicious and you have to judge the spectrum and the variety of the symptoms. This is always goes with sepsis. Then you have to prove it is sepsis or not, because you will be on the safe side. You will save the life of your patient. Now, you have diagnostic tests or you have diagnostic tools. Of course you have. What are these? We can classify it to non-specific and diagnostic. What do we mean by non-specific? Diagnostic means presence of its diagnosed sepsis, but it is not specific. It can increase or it can change in other conditions. The examples is the total white BC counts, or the ratio between the immature and mature neutrophils, C-reactive protein, micro ESR, and we will explain what is micro ESR, and procalcitonin, and miscellaneous tests. Presence of these, if it is positive, it is diagnostic, but it is not specific. Can increase or can change in other conditions. While the definitive or the specific test, presence of it, or when it is positive, this is specific for sepsis. So it is very important and valuable more than the non-specific, like the blood culture, the CSF examination and culture, the urine culture, the tracheal aspirate culture, or body surface culture. So you can see culture of everywhere. Umbilical swab, axillary swab, rectal swab, and urine culture, and again, of course, PCR is very important, and the latex agglutination test. These are definitive, specific, superior on the non-specific, of course. So I will talk about the blood culture. Blood culture, it should be done primarily. In the incubation period, it is about 72 hours before being considered negative. So before 72 hours, if it is negative, it is of no value. But if we go to the blood culture, always it is definitive. That means there is no limitation for the blood culture. No, we have limitations for blood culture, and we have to know them. Because blood culture, it may be negative in about 20% of cases that are proven by immediate post-mortem culture and autopsy. And false negative rate, false negative blood culture, it will increase in mild symptoms and the earliest onset of septicemia, like what happened now in COVID-19. In the mild cases or in the early onset of the disease, it may be the PCR negative, but the baby infected. Oh, sorry, the person is infected. Negative, the blood culture, it may be negative in about 50% of patients with congenital bacterial pneumonia. It is proven by the tracheal aspirate culture. And it may be negative in about 40% of infants with meningitis. So you have to know these limitations of blood culture. The other tool of examination or of the diagnosis, which is specific, the CSF examination and LP examination. It is valuable in symptomatic infants who have a high risk factor for sepsis. And it is preferable to be done prior to antibiotic therapy. It's better to start to do before starting the antibiotic therapy. It is difficult in an unstable patient. We cannot do it in an unstable patient because it may lead to apnea or even death. Sometimes meningitis may be present. This is, again, another limitation, with the presence of normal CSF picture. So what are the indications to do CSF? All suspected patients with sepsis, we will do CSF? No, we have indications. any infant with positive blood culture. So don't stop on the positive blood culture. Go to do the CSF examination. Infants with a clinical course or lab data strongly suggest the bacterial sepsis, like the C-reactive protein, procalcitonin, the micro-ESR, all those increase the risk. Or infants who initially worsen with antimicrobial therapy. You start antimicrobial therapy, but there is no response. So this is indication to do CSF examination. This is, you see here, this is a normal finding of the CSF analysis and outside of the neonatal period. But specifically in the parameters of the CSF in neonates, it changed. So the leukocytes, it may be up to 30% and more than 60% of them polymorph neutrophil. The glucose is about 50% of blood glucose, so we should do the blood glucose at the time of doing CSF. The protein may be very high, up to 150 in term babies and up to 180. You can compare between the normal parameters of CSF and out of the neonatal period and in the neonatal period. And the diagnosis is suggested by abnormal result. So abnormal result of CSF is just suggested. And the proof is by doing, or the confirmation is by doing CSF culture. Now, we say the neonatal sepsis is classified into early onset and late onset according to the onset of the symptoms. We have another classification, which is proven sepsis. And I think you remember this term, proven sepsis, when we talk about the incidence, and the suspected sepsis, or the probable sepsis. So the proven sepsis, the baby present with a clinical picture of sepsis. Clinical picture, now you know, it is diverse, it is wide, with wide spectrum. This is first, for the proven sepsis. Then, isolation of pathogens from blood, by blood culture, CSF culture, urine, or other body fluids or autopsy evidence of sepsis. So this is a proven sepsis. Clinical picture and culture from body fluids, blood and etc. While the probable sepsis or the suspected sepsis, this is the newborn with a clinical picture suggestive of sepsis, with one or more of what? Existence of predisposing factors, example, maternal fever or foul smell, liquor or prom more than 18 hours. Name 2, positive sepsis secret. What is the positive sepsis secret? We have 4 sepsis secret. 2 of these 4, when the total white BC less than 5,000 or the absolute neutrophil count less than 1,000. The ratio between immature to mature neutrophil is more than 0.2. When the C-reactive protein positive, and when the micro-ESR, it's more than 15. So what is micro-ESR? It is the ESR that taken by, if it's more than 1 hour, or the age of a neonate is in day +3. So if the age of a neonate is 9 days, plus 3, it is a 12. So anything more than 12, it's regarded as positive or high ESR. These are for the sepsis secret. So 2 of them, with the first one, which is the existence of predisposing factor, risk factor, making it with the probable sepsis. 3 is the radiological evidence of pneumonia. So, as I said here, for probable sepsis, 1 or more of these. 1 or more of these. Now, how we can approach to neonatal sepsis? Now we are dealing with a patient suspected to have sepsis. How we can approach to it? So, firstly is approach to suspected late onset sepsis, because this is common in practice, coming after the 72 hours. So, from definition, neonate symptomatic after 72 hours must be evaluated for late onset sepsis. 30% of a neonate clinically suspected to have LOS in a neonatal intensive care unit setting have positive blood culture. This is high. So a single episode of a transient presence of one of signs of lethargy, poor feeding, and hypothermia may not warrant an action if it is single episode or for just one episode. But if it's recurrent, no, it increases the risk. So the more persistent the sign, persistence of these signs, are the more likely the patient to has late onset sepsis. How we approach to patient with suspected early onset sepsis. Here, you have to start antibiotic after taking blood culture in. You have to start antibiotic after taking blood culture in. Symptomatic in neonates with any risk factor. You know the risk factor, maternal and neonatal. Chest X-ray suggestive of pneumonia. Those do not have any alternate explanation for the signs. Start antibiotics. LP must done in all symptomatic neonates, except premature neonate presenting with RDS at birth with no risk factor of sepsis, because here the cause is explained and is none. Now, based on a clinical assessment, the neonate with late onset sepsis must be categorized into late onset sepsis, low probability and high probability. Who are those with low probability and how we can approach to them? Neonates with low probability of sepsis should undergo a sepsis secret. What is the sepsis secret? The 4. The purpose here of sepsis secret is to rule out the sepsis, not to rule in the sepsis. So what are the sepsis secret? I remind you, the absolute neutrophil count less than 1,000, the ratio between the immature and mature neutrophil more than 0.2, the positive C-reactive protein, and the high micro ESR more than 15 or more than the age of the baby plus 3. These are the sepsis secret. If all parameters are negative in case of low probability, all are negative, antibiotic may not be started and the neonate must be monitored clinically. The monitor is just enough. If the secret must be repeated after 12 to 24 hours, and 2 consecutive negative secret are suggestive of no sepsis. Repeat, and negative mean no sepsis. Now, what is the treatment of neonatal sepsis? Any treatment of a neonatal sepsis, we have 2 lines. We should start immediately at the same time because they have the same importance and the same validity, which is the supportive care and the antimicrobial therapy for the suspected or non-pathogen by culture. So, startly, there is no investigation is required as a prerequisite to start a treatment in a clinically obvious case. Start the treatment. Don't wait for the investigation. Early treatment is crucial, very crucial. Institution of a prompt treatment is essential for ensuring optimum outcome. Supportive care and antibiotics are 2 equally, as I said, and components of the treatment. Supportive care, it makes the difference, not the antibiotic. The antibiotic need time to act and need time to see the response to antibiotics. But what makes the change, what saves the life, is the supportive care. What is the supportive care? Normalize the temperature, hypo or hyperthermia. Stabilize the cardiopulmonary status. Correct the hypoglycemia and prevent the bleeding tendency. These are very important and crucial and essential and have a high value in changing the result and saving the life. Now, we come to the antibiotic therapy. The early onset sepsis, what is the antibiotic therapy preferred to start with? We have the combination which is called ampicillin plus the aminoglycoside. These are the empirical and universal, but we can use 3rd generation cephalosporin, cefotaxime, but avoid ceftriaxone. This is from the last lecture of neonatal jaundice, and you should know why. ceftriaxone, because it will compete with the binding protein and will cause cholestasis and lead to risk to the kernicterus. The late onset sepsis, because here the risk of the Staphylococcus coagulase negative staphylococci because of the indwelling catheter, so we prefer to start with vancomycin, which is the drug of choice, and initial broad spectrum coverage with third generation cephalosporin. If Pseudomonas aeruginosa is suspected, we start with ceftazidime or aminoglycoside with vancomycin. Vancomycin must be stopped as soon as culture and sensitivities indicate that is not needed, because we are afraid of the resistance to vancomycin. Now, what are the duration of antibiotic therapy in sepsis? For how long we will stay on the antibiotics? For proven sepsis, and you know proven sepsis, culture positive. Pneumonia, 10 to 14 days. Proven meningitis due to GBS, the gram-positive beta-hemolytic streptococci, minimum is 14 days. While in proven gram-negative meningitis, it may extend to 21 days after obtaining a negative culture. In osteomyelitis, and septic arthritis, and cerebritis, and endocarditis, the duration is up to 6 weeks. And in UTI, it is 7 to 14 days. In cases of low suspicion of sepsis, the antibiotic may be stopped after 3 days if the baby is well and the negative culture. No need to continue on antibiotics. But if the baby appears ill, though the culture are negative, antibiotic therapy should be continued for 7 to 10 days as bacterial infection can occur with negative culture. You know the limitations of the cultures. So, can we change antibiotic? Yes, this is called the empirical upgradation of antibiotics. This must be done if the expected clinical improvement not achieved within 48 to 72 hours. There is no response, so you can upgrade the antibiotic to more potent. Now, we reach to the end of our lecture, and we are talking about prevention. From the objectives, we say how we participate in prevention of the neonatal sepsis. So firstly is the good antenatal care, because good antenatal care will increase the incidence, the morbidity, and the mortality. All mothers should be immunized against tetanus, because it's very important. That's why I usually ask about the tetanus toxoid during the prenatal history. Early diagnosis and prompt treatment of infected pregnant mother should be treated promptly. The only intervention proven to increase the incidence of early onset sepsis, because this is related to the mother, we say before, intra, and shortly after the birth, is the maternal treatment with intrapartum and IV antimicrobial agents for the prevention of the gram-positive beta-hemolytic streptococci. This is the rule, of course, of the obstetricians. And babies should be fed early and exclusively with expressed breast milk or breastfed. Mother cannot lactate her baby, we can't take the milk from her, or direct feeding without any pre-lactal feeds, because you know the importance of the breast milk on the aspect of the immunity. Care of umbilical cord is very important, because some of the infection acquired through the onphalitis, through the infection of the umbilicus and the umbilical cord. Unnecessary intervention should be avoided. So that's why in patients here in our ICU, especially the preterm low birth weight, it's not important to put your hands inside the incubator and just to auscultate the heart or palpate the abdomen or just touch the patient. You may transmit the infection to the baby. So unnecessary intervention, should be avoided. And of course, the hand washing before touching the babies. Each baby, before touching at home, at hospital, you have to thoroughly wash your hands, the thoroughly and the medical, which is up to 20 seconds. This is simple and most effective method. So please spread this message to your families. Always prevent the infection by hand washing and decrease the intervention with the babies. And of course, avoid kissing, avoid direct contact, avoid come in the breathing in the faces or in the of the babies. And thank you. Now we reach the end of our lectures.